Management of intracapsular fracture neck of femur. We have already discussed the classification, logic, and prognosis of intracapsular neck of femur fractures in the previous two videos. So now, since we already understand why the fracture behaves the way it does, I will continue with how the surgical management is actually planned. Here, choosing the correct index operation is extremely important. Because while we are trying to maintain mobility and fracture union, a wrong first decision can compromise both. In general, two types of patients walk into the emergency with this fracture. The first is the young John, riding his bike at full speed and meeting with a high energy trauma. The second is old Janki Amma, who slips in the bathroom and sustains a trivial low energy fracture, usually in an osteoporotic bone. This describes the epidemiology of these fractures. But irrespective of who the patient is, our final aim while fixing a neck of femur fracture remains the same. We need to preserve the native joint space whenever possible and enable full, unrestricted weight bearing as soon as possible. There are two subsets where the decision is very straightforward. 1. Pathological fractures. If the fracture is pathological, there are three major problems. First, low healing potential. 2. Poor bone stock. And 3. Any intramedullary procedure can generate metastasis through embolization. So in these patients, we do not attempt fixation, we directly offer arthroplasty, which can either be hemiarthroplasty or total hip arthroplasty. 2. Pre-existing osteoarthritis. If the patient already has a symptomatic pre-existing osteoarthritis of the hip, you directly plan a THR. Now comes the most important group, the patient with no pathology and no osteoarthritis. Here, you look again at the only thing that truly matters, displacement. This must be assessed in both AP and lateral views. That is, a less than 20 degree posterior tilt and a less than 10 degree anterior tilt on the lateral X-ray too. If these limits are maintained, the fracture behaves like an undisplaced fracture. Now, in the undisplaced subset, that is Garden type 1 and type 2, we try to preserve the femoral head and opt for fixation or osteosynthesis. A Garden type 1 fracture can be tried conservatively with reduced weight bearing, close follow-up for displacement. However, prophylactic fixation is very commonly performed. Well, because union rates are very high, avian rates are very low. In Garden type 2 fractures and the type 1 fractures which were fixed prophylactically, these are managed by osteosynthesis, right? There are two major implants for osteosynthesis. One is multiple cancellous cannulated screws or the CC screws, and 2. Sliding hip screw or dynamic hip screw, the DHS. As we discussed earlier, as Pauwels type 1 shifts to type 2 and type 3, the shear forces increase. There is a greater need for angular stability. The DHS is the implant which converts shear into compression and therefore provides better angular stability than any CC screw. On the other hand, CC screws require a very small incision, leaving a smaller biological footprint. So, as the Pauwels angle increases, the preference gradually shifts from CC screws to DHS. Now coming to Garden type 3 and 4, which are displaced fractures. Now displacement means an obvious displacement on the AP, and on the lateral view, you will look for 20 degrees posterior tilt and 10 degrees of anterior tilt. The next factor you assess is the physiological age of the patient. When we refer to a patient less than 60 years, we are focusing on their physiological age rather than the chronological age. So physiological age refers to the biological and functional condition of the person, not just how many candles are there on their cake or the chronological age. It considers factors like health status, fitness level, and organ function also. So like a 60-year-old in great health with an active lifestyle may have a physiological age of someone in their 40s, while a 60-year-old who is frail, has multiple health issues, or is largely immobile may have a physiological age which is closer to that of someone in their 70s or 80s. So in patients less than 60 years, we attempt to reduce the fracture and convert it into an undisplaced variant. After reduction, the fracture is treated like the same way we treat in garden type 1 or type 2, the undisplaced variant. You may wonder, if the blood supply is already damaged, why reduce it? Because even after initial arterial injury, stable fragment fixation and decompressing the intravascular compartment by capsulotomy, reduction, and fixation can allow revascularization of the femoral head. Now, this revascularization has to occur before any avian or collapse develops. The second reason is that in a young patient, we always try to preserve the native joint. See, a THR has a finite lifespan. A young patient generally outlives the implant, and because of high activity, early replacement leads to faster wear, more revisions later on. So we would prefer to do fixation in these cases. Prefer, because even success in these cases which have been converted to undisplaced fracture depend heavily on one thing: reduction quality. For Janki Amma and patients above 60 years, the strategy changes. Here, we prefer arthroplasty or joint replacement surgery. Now you have to decide between hemiarthroplasty and total hip arthroplasty. See, if the patient walks independently outdoors, is not cognitively impaired, and is medically fit for anesthesia, you plan a THR. Hemiarthroplasty is reserved for high anesthesia risk patients or cognitively impaired patients, those patients who are more likely to dislocate a THR repeatedly. So, in these patients, we tend to follow a quick in, quick out philosophy. By now, I'm sure you can name the complications on your fingertips. The major complications include avascular necrosis, AVN of the head, collapse of the femoral head, non union, secondary arthritis of the hip joint, limb length discrepancy. Usually, this happens due to shortening of the affected limb. Now, in addition to these, there are also general complications which are common to all surgeries, such as infection, DVT, medical and anesthesia related complications. See, I've skipped delayed and neglected neck of femur fractures purposefully because their logic and implants play a completely different game. Now, if you want that video, you need to tell me in the comments. Having said all this, I'll tell you something very frankly. Despite all these algorithms, a surgeon will always choose the one he is most comfortable in. The one surgery he can predict very easily, the one surgery he has on the tips of his hands. That is a surgeon's preference. The chief operating surgeon's preference should always be respected because the onus of bone union is on the surgeon. If this video saved you from one more exam panic, hit the like button. It deserves the credit. And if any concept still feels shaky, drop your doubt below. Subscribe for orthopedics without mugging, only understand. See you next time.